Okay, we are going to finish up our last GI chapter, which is chapter 43, over liver, biliary tract, and pancreas disorders. So we're going to head right into this. Don't forget there are notes in the notes section, so just let me know if you have any questions based on those. And we're going to start off with the anatomy of the liver. So first of all, it's located under the diaphragm in the right upper quadrant. We've seen that in previous chapters, and it does go quite up higher than you would think, up to like the 6th or 7th intercostal space. So it goes up pretty high into the right side of the lung space. The hepatic artery brings oxygenated blood to the liver. So that makes sense. There is an artery that delivers blood to all organs from the heart. And then the liver receives nutrients from the GI tract via the portal vein. So that's the vein where venous blood from the GI system is going to go into the liver, deliver nutrients to the liver, be detoxified, and then sent back to the heart. And blood will be sent back to the heart via the hepatic vein, which will then dump into the inferior vena cava and get delivered into the heart. And so this is like what kind of the vasculature of the liver looks like. The liver is a very vascular organ. The common hepatic artery here is what breaks off of the aorta and then delivers oxygenated blood to the liver. Then we also have the common bile duct, which we know is what's going to combine the liver, the gallbladder, and the pancreas to drop digestive enzymes and bile into the duodenum. And then this here is the portal vein. So that's what's taking deoxygenated blood from the GI organs to the liver, providing nutrients to the liver and detoxifying the blood to make it safe to be delivered back to the heart through the hepatic vein. The functions of the liver, there are numerous functions. First of all, it produces and excretes bile. That bile is then stored within the gallbladder. The metabolic functions that it plays a role in are glucose to glycogen for storage. So we talked about that in the diabetic section. Stored glucose is glycogen. And so when the blood glucose level is low, glucose can be made from glycogen, or it can be stored when glucose is high. So glucose to glycogen for storage, and then glycogen can become glucose when the blood sugar is low. It also synthesizes several proteins, and one that we're specifically interested in is albumin, which is the one we talked about in the previous chapter that holds volume in the vascular space, which is what we want to see. And then lipid metabolism, it manufactures cholesterol, and then cholesterol is also used to make bile, and bile again is used for digestion and absorption of dietary fats. It also plays a role in blood coagulation. So if you have altered liver function, you'll oftentimes have altered clotting function and be at risk for bleeding. It produces clotting factors prothrombin and fibrinogen. And if you went over that in any kind of like microbiology course or maybe a pathophysiology course, you would have gone into the clotting cascade into a lot more detail. And prothrombin and fibrinogen are both pro-clotting factors, and they are produced by the liver. The liver also plays a role in detoxification, of course. It will detoxify poisonous substances and break down nitrogenous wastes or ammonia to urea. So ammonia and bilirubin. Bilirubin is what gives your urine the yellow color. Ammonia in the urine is what gives it that distinct smell. And we'll talk about the role that a buildup of ammonia in the body will cause in just a few slides here. It plays a role in hormone metabolism, so it'll break down hormones such as aldosterone, cortisone, estrogen, and testosterone. If you remember, those are all adrenal gland hormones. When they have done their job and the body is done with them, they go through the liver to get broken down and then excreted and exit the body. And then it also plays a role in storing vitamin B12 and fat-soluble soluble vitamins, which are A, D, E, and K. So when we have liver disorder, something called jaundice can occur. It's not a disease, but it is a symptom of liver malfunction. And what happens here is there's a yellowish discoloration of body tissue. Icterus is like the medical term for yellow. So one thing you'll hear, like this picture shows, this is scleral icterus, scleral, SCLERA, scleral icterus. And then we can also see yellowing of the skin. If you've ever been around anybody that has jaundice, it's pretty obvious. I've seen people look pale yellow all the way to like highlighter yellow. And it results from an accumulation of bilirubin in the blood. If you remember, bilirubin is the breakdown of hemoglobin, and that is sent to the liver to either be reused as a product to make bile, or it is going to be excreted through the urine. So if the liver can't properly break that down, then there's going to be an overaccumulation of bilirubin. And then when that happens, that's when we see this yellowish color of the skin and eyes. And that's basically what this slide says. So if there's too much bilirubin, that means that there's an increase in RBC or red blood cell breakdown, or the body's having a difficult time removing it. Either there's some kind of blocked duct, like the common bile duct might be blocked, or there's a liver problem, which is usually what the issue is. Hyperbilirubinemia is another word you'll hear used for this overaccumulation of bilirubin leading to jaundice. Jaundice can further be classified into 3 different types. There's hemolytic, which means, and these classifications are talking about the cause. What is the etiology behind the jaundice? Well, there's hemolytic, which is the increased breakdown of red blood cells and hemoglobin. There's hepatocellular, which is from damaged hepatocytes. That's the more common one from liver disorders. And then we also have obstructive. So that's what we were talking about here. Something's blocked. So a tumor can block things. Hepatitis, the inflammation of hepatitis can block different ducts and glands. Gallstones within the gallbladder can certainly obstruct different ducts, and cirrhosis. So cirrhosis is actually could be categorized as hepatocellular or obstructive, because cirrhosis is like end-stage liver dysfunction. And we talk about that in a few slides. Again, the clinical manifestations of jaundice, you do need to know these. They're very textbook symptoms of jaundice. Of course, we have the yellow sclera and skin, and then stool is clay-colored, and urine is tea-colored. You can see here, that's like a sweet tea or a Coca-Cola. That happens in conditions with liver disorders causing jaundice, or in something called rhabdomyolysis, which you'll learn about in critical care. Pruritus, so that accumulation of bilirubin will cause the skin to itch, and then fatigue and anorexia. Now we're going to talk about hepatitis, and there are several different types of hepatitis. The most common ones are viral. So the meaning of hepatitis, if you break it down, itis is inflammation or infection of, and then hepata is, or hepa is the prefix for liver. So the different viral types that we talk about are A, B, C, D, E, and G. We're going to talk about each of those in the following slides. If it's not viral, it can also be caused by chemicals, toxins, or alcohol. Alcohol would be the next most common type. Other viruses that are known to cause liver inflammation and damage, they're a little more rare, but they can cause a hepatitis and exacerbate symptoms, is cytomegalovirus. That's one that we get during, sorry, my computer just kind of wigged out. The cytomegalovirus is one that you may have heard about, because if any of your patients have the cytomegalovirus or CMV, you may have heard it called. Pregnant nurses or pregnant healthcare providers should not take care of those patients, because if that nurse were to contract CMV, it can cross the fetal mother barrier and can be transmitted to the fetus. Epstein-Barr virus is mono, herpes virus, and CMV is actually a type of herpes simplex virus, rubella, and then Coxsackie virus. So the only way to distinguish between the different causes of hepatitis or which type of virus it is based on the presence of a viral antigen and subsequent development of antibodies in the blood. So anytime you have started a job at a healthcare facility, a lot of them will draw a blood titer before you start as part of like your kind of like your physical before you get into that institution. And one that they commonly take a titer of is hepatitis B, because we do get a vaccine for that, and it's one that you get as a baby in a 3 series dose. But over time, you can lose like the efficiency of that virus, so you can get a booster shot. When I was a CNA in nursing school and started at Baptist, they took a blood titer and saw that I didn't have enough antibodies to Hep B, so they just redid my Hep B series, and then they redrew the titer, and I was good to go. So that's how they can kind of draw your blood and see, test what different forms it could be, and that's how we could know, because hepatitis in many ways is going to present with the same symptoms. It's just transmitted differently per the different viruses. And if you are particularly interested in this, there are several stats on hepatitis in the United States, what kinds are most common, things like that you can look on the CDC website, and I'll put that link in here for you. So hepatitis A, the mode of transmission is fecal oral. So that can occur when there's any kind of fecal contamination and then followed by oral ingestion. So this is when you go to like a restaurant and they aren't doing good hand hygiene. They go to the bathroom, they don't wash their hands, they come and touch your food. That could be a way that they transmit hepatitis A in a fecal oral route. It is relatively uncommon in developed countries because there is a Hep A vaccine. And so the occurrence of Hep A has decreased by 92% since then. Common food sources of this are shellfish and just unsanitary food handlers, and ingestion of food or liquid that's infected with the virus obviously can cause transmission, or oral anal sexual activity. This particular Hep A is more common in countries with poor sanitation. Hep B's mode of transmission, B is for blood and body fluids. So it is contracted by contact with semen or saliva that contain blood. The virus can be transmitted through tears, feces, urine, breast milk, or sweat, only if there's blood present. So in normal, common contact with people, it's not going to be a risk of contracting or exposing somebody to Hep B, only if blood or semen or saliva are in those body fluids. Hep B can live 7 days on dry surfaces, so that's why certain hospital wipes are used for certain surfaces, because they will kill the Hep B, where other certain sanitation wipes won't. Major sources are carriers and clients in any phase of the infection. So just like with most viral illnesses, even before you present symptoms, you can be contagious. During symptoms, you can be contagious. And then for a phase after symptoms resolve, you can be contagious. Again, common modes of transmission are unprotected sexual intercourse, sharing needles, needle or sharps injuries, although that is a low incidence. If you are stuck by even a dirty needle in the healthcare system, that is very scary, but also just know that if you are a healthy, non-immunocompromised individual, that very small amount of exposure to that very small amount of blood puts you at a very low risk of contracting anything, even if they did have Hep B or Hep C. Hemodialysis can cause this, like dirty hemodialysis, dirty blood transfusions. However, the screening process has been so, updated and such a good process since 1992 that it's a very, very, very extremely low risk. However, if we have anybody that received a blood transfusion before 1992, that may be how they got Hep B, and then the maternal fetal route. Most clear the virus and develop immunity after contracting it, but some can become chronic carriers. So even if they don't have symptoms and they're not actively sick, they can infect others. The Hep B vaccine is going to be recommended, obviously pre-exposure, it's recommended to all babies. I think it's like 2, 4, and 8 months, 2, 6, and 8 months or something like that. I'm not a peds nurse, so don't quote me on that. That provides active immunity. Post-exposure, so once you've been exposed to Hep B, the vaccine's not necessarily going to help you, but we will give you a combination of the Hep B vaccine to rebooster you, and then give Hep B immune globulin doses to help treat the infection. Now, anytime you're given these post-exposure medications, they usually come with a lot of GI side effects, so that's something we have to educate our patients on for this. Hep C, you can remember C is for contaminated needle and carriers, very similar to how Hep B is transmitted. In the US, 60% is transmitted through IV drug use and dirty needles. High-risk sexual behaviors like unprotected sex and multiple partners can put you at risk for Hep C. And then there is a risk associated with unsanitary body piercing and tattooing. It cannot be transmitted via casual contact, just like Hep B. Whatever body fluid or unsanitary needles or piercings, they have to be dirty with presence of blood on them. There is no vaccine for Hep C. However, and this is so cool because when I was in nursing school 5 years ago, we didn't have a treatment or a cure for Hep C, and now we do. So that's super, super exciting. There are antiviral medications we can give for Hep C, and there's a cure. So that's super great. Hep D, the unique thing about Hep D is that the patient must have Hep B in order to contract Hep D. It will not, you can't just have Hep D, you have to have Hep B first. Again, it's transmitted the same as Hep B. And there's no vaccine and no treatment. However, if you are protected against Hep B, you're going to be protected against Hep D because Hep D requires Hep B, as in boy, to be able to replicate. Hep E, if you can remember E for enteric. It is waterborne fecal oral, similar to Hep A. It is rare in the US and it's much more common in countries such as India, Mexico, and Africa. Now, for all hepatitis diseases, regardless of the viral cause, they share 3 phases. So the first phase is prodromal, which is nonspecific signs and symptoms. This begins 2 weeks after exposure. They are going to experience very generalized flu-like symptoms, malaise, fatigue, body aches, anorexia, nausea, vomiting, diarrhea. They may even develop that upper abdominal pain and weight loss from that anorexia that they're experiencing. During this phase, they probably do not know that they have hepatitis. However, they are highly contagious. Infection is highly transmissible at this stage. The icteric phase, and you can remember that because icteric is jaundice, so that's when they're going to experience specific signs and symptoms related to liver dysfunction. So again, we're going to have the icterus, jaundice phases, the yellow skin, the yellow eyes, tea-colored urine, pruritus, clay-colored stools, all of those symptoms with jaundice. That's what they're going to experience. And this occurs between 1 to 2 weeks after the prodromal phase. In rare situations, patients can have anicteric hepatitis, meaning, without icteric symptoms, without jaundice, but that is a little bit more rare. Usually, hepatitis is going to cause enough liver dysfunction to have bilirubin accumulate in the body and cause jaundice. Then there is the third and final phase, recovery. So this is the resolution of jaundice. They're going to start feeling better, have an increase in energy level. Their GI symptoms and pain will start to resolve. However, their liver still may be enlarged and tender. So where they may not have abdominal pain, just like sitting, not doing anything, if they get involved with a lot of physical activity, or if you were to palpate the right upper quadrant, they may report some tenderness. But again, even though these symptoms are getting better, they are still contagious, and they need to be aware of that because they don't want to pass this on to anybody else. What are we going to see diagnostic studies wise for patients who come in with hepatitis? Well, first of all, our liver enzymes are going to be elevated. So AST, ALT, and ALP, we talked about those in the first chapter, going over different labs and diagnostic tests. They're going to be elevated because they are indicators of liver function. So anytime they're elevated, that means that something's wrong with the liver. Bilirubin's obviously going to be elevated. They're experiencing jaundice. They're not excreting it as they should be. So bilirubin will be elevated. And then they're not producing clotting factors. If they're not producing that prothrombin and fibrinogen, because the liver is injured and not working, it's inflamed and sick, then our prothrombin time, our PT and even PTT, are going to be prolonged. So they're going to be elevated. And that's because PT and PTT are clotting times. They measure how long it takes the body to clot. If we have a deficiency of clotting factors, then it's not going to clot quickly. So basically, instead of functioning within the normal clotting time with normal clotting factors, since they don't have it, it's going to take longer for a clot to form. If that doesn't make sense, if I didn't explain that well enough, just let me know and shoot me a text or email. Sorry about that. And then what's going to be decreased is albumin. So because the liver is injured and ill, it's not going to produce albumin, which of course we've already talked about the body needs to keep volume in the vascular space. So the albumin on labs are going to be decreased. How are we going to manage hepatitis? So there is no specific treatment or therapy for hepatitis, with the exception of Hep C, which does have a cure now. But the emphasis becomes rest. Just like any viral disorder that you may get, a viral GI bug, whatever, viral sore throat, there is no specific treatment. You just kind of rest, stay hydrated, and let the condition run its course. So rest the liver, promote hepatic cell regeneration. The liver is the only organ in the body that will regenerate, so that's good. As it's healing, it's going to regenerate and get back to normal. Fatigue is worse in the early phases, so we want to encourage them to space activities, prioritize activities, and get lots of rest. Their diet should be high in carbs and calories and moderate in fat and protein intake. Small meals are better just so that the liver isn't, again, it plays a role in digesting food. So smaller meals, giving the liver just a little bit to do at a time is more helpful. Multivitamins, and then if the PT is severely elevated, we can give them vitamin K. Vitamin K is part of the clotting cascade. So if we have elevated bleeding times, clotting times, then giving vitamin K should bring that back down to normal. And then to relieve their nausea, we can give antiemetic medications. One thing I want to point out is if you go back to, as you're studying the normal functions of the liver, it's going to match up. If you learn what those normal functions are, what their normal roles are, so go all the way back here to what the normal functions of the liver are in the first handful of slides, then you're going to know when the liver isn't working properly, all of these things are going to be altered. They're not going to be working appropriately. So that's where, this blood coagulation comes from. The taking a multivitamin, they're not storing it properly. So we need to give them the multivitamins. They are going to have a buildup of ammonia. Their blood sugars could be off. Their albumin's going to be low. Bile could be low because we're not properly converting bilirubin into bile. For digestion of fats. That's why we want to be careful about our fat intake and keep it low to moderate, etc. So just keep that in mind while you're studying. Ineffective health maintenance is going to be one of the nursing diagnoses that we focus on here. So we want to teach prevention of transmission by teaching about good hand washing and hand hygiene, promoting safe sex, and then giving information and pamphlets on the needle exchange programs around. And then if they are taking any hepatotoxic medications, they need to stop them. DC the hepatotoxic meds. So anything that's given and metabolized through the liver. Those would include things like estrogen. So if they're taking estrogen supplements or birth control, then they need to stop it while they're in this acute hepatitis phase, because that's just going to raise bilirubin further and worsen their symptoms. So they need to get off that. Suki. Sorry. Tylenol, acetaminophen is metabolized through the liver, so they need to not take that. And then sedatives are also metabolized through the liver. Hang on just a second. Okay, additional maintenance of hepatitis is drug therapy for Hep B and C. The goal is to reduce the viral load and the rate of the disease progression. So we want to slow it down, get it under control, support their symptoms. There are antiviral medications for Hep C, and then we would re-give the Hep B vaccine and then the Hep B immunoglobulin medications. So for toxic hepatitis, so if the patient developed hepatitis in response to a chemical or medication, that can cause necrosis and develop into renal failure. So we're very concerned about that. We would want to stop those medications and get in contact with the Poison Control Center. They would help guide specific support and treatment for that particular overdose of chemical or medication. Alcoholic hepatitis occurs in response to alcohol intake, of course, chronic alcohol intake. Symptoms occur immediately after heavy drinking. And then if they continue to drink, a lot of people, this puts them on the path to sobriety because they don't want to experience these symptoms. If they aren't able to stop due to their addiction, then they kind of have poor outcomes associated with that. Now we're going to talk about cirrhosis. So cirrhosis is extensive, irreversible scarring of the liver. So damage has occurred over time continuously, and it's led basically to this end-stage liver disease. The cause in the United States is usually alcohol and Hep C. Globally and in lower developed countries, it's going to be Hep B and Hep D. Without a liver transplant, this is a fatal diagnosis. This will lead to death because you cannot live without your liver, and this is causing complete liver dysfunction. So the pathophysiology of cirrhosis is that there's inflammation of the liver caused by a toxin or disease, which causes destruction of hepatocytes or liver cells. So this can be from a acute or repetitive overdose of certain medications or toxins. It can be from chronic alcohol use. Chronic uncontrolled hepatitis can cause this. With the overgrowth of fibrous connective tissue will come changes in the actual structure of the liver, from a lobular, nice, healthy, smooth liver, which is down in this left side, to a nodular one, like down over on this right side. And just like we've talked about with cancers and with GERD and esophagitis, we were talking about how exposure to the gastric acid caused the esophagus mucus producing cells to change into intestinal type cells. So that's no good. That's basically what's happening here. The cells are changing from lobular physical structure to nodular. Anytime cells change like that, they're not going to function properly. They're not going to play their role as they should, and they're not going to complete their functions as they should. So these nodules can further block bile ducts and normal blood flow throughout the liver. So not only can it not produce its own liver functions correctly, which we saw in the beginning, there's a million of them, but it's also going to block the bile ducts, which we know is a problem, and block normal blood flow. Blocking normal blood flow and perfusion is going to lead to ischemia and further death of cells and, worsening the liver function. So it's bad all around. The different types that you can see, there's biliary cirrhosis, which is from chronic biliary obstruction, things like gallstones. So if patients have continuous gallstones or a tumor that continually obstructs the biliary bile duct, that can be a problem. Jaundice is the primary symptom of this. There is cardiac cirrhosis. So when we were talking about in the cardiac section, right heart failure leads to blood backing up into the body, and we see things like JVD, peripheral edema, anasarca, and we see congestion into the liver. Well, over time, severe long-standing right-sided heart failure will lead to cardiac cirrhosis or liver failure because of that chronic congestion of blood. And then Lanac cirrhosis, also called alcoholic cirrhosis, that's from chronic alcoholism. And then the last kind here is non-alcoholic fatty liver disease. So this one's also fairly common. It presents very similarly to alcoholic cirrhosis, and it's an accumulation of fat in the liver, but it's not caused by alcohol and it's not caused by hepatitis. So we don't really know what the particular cause is, but hepatocytes undergo the fatty changes, leads to inflammation and scarring, and then that leads to cirrhosis, of course. The change in that tissue leads to dysfunction, and then the organ's going to fail. It is strongly linked to obesity. So while we don't have a great understanding of it, we have seen that it is highly associated with obesity, and that accumulation of fat kind of makes sense. Oftentimes, obesity is due to an overabundance of calorie intake and fat intake, and so that kind of goes hand in hand there. Meds that cause that we have seen cause non-alcoholic fatty liver disease are cardizem or diltiazem, which we've talked about as a calcium channel blocker, and it's it can work as an antidysrhythmic as well. And then amiodarone is also an antidysrhythmic. So while we certainly need to give those meds if the patient's in some kind of cardiac need of it, in some conditions it has led to non-alcoholic fatty liver disease. Clinical manifestations. We have several slides of conditions and complications of cirrhosis here, and they are all the slides. So let me kind of show you here. These all gray slides are complications or kind of like associated conditions that occur with cirrhosis. These slides right here that are black and white are going to be directly related to clinical manifestations of liver failure. So just so you can kind of follow along here, the clinical manifestations early on is going to be very insidious in onset. The GI symptoms are going to be generalized. We'll have dyspepsia, flatulence, nausea and vomiting, change in bowel habits, dull abdominal pain, especially localized to the right upper quadrant, and then hepatomegaly. If you can see here, this is almost like cancer. The insidious onset, the dyspepsia, the generalized change in bowel habits would make you almost think, okay, they might have like a colorectal cancer or something. That's where the workup would come into play. That's why we'd have to order several different diagnostic tests to delineate what's going on here. Late signs are jaundice because we can't conjugate bilirubin, we can't process it and turn it into the form that we need it to use for bile, or because we can't excrete it. We know what jaundice is. We've talked about that. And then skin lesions may occur. And this occurs because the liver is failing. It can't properly metabolize steroid hormones. So our hormones that are made from the adrenal gland, the aldosterone, our estrogen, testosterone, cortisol, they can't be properly metabolized and excreted from the body. So an overabundance of them can cause these skin lesions like spider hemangiomas and things like that. Late clinical manifestations are also endocrine problems related to the fact that we can't metabolize hormones. So the same reason we were talking about with the skin issues, the adrenocortical hormones are going to be, what am I trying to say? Retained, like they're going to be in the body for longer and have their effect for longer. So we're going to be retaining that sodium in water for longer than need be. So we could have hypernatremia. Definitely we could have an overabundance of fluid, and then potassium is excreted. So we could have low potassium. We need to watch for that. And then if we can't metabolize estrogen and testosterone, then we're going to see things like gynecomastia, impotence, testicular atrophy, and amenorrhea. These are similar to Cushing's syndrome. So if you remember, Cushing's syndrome is when there's an overproduction of adrenal hormones. This is presenting in the same way. This is exactly these skin lesions, this holding on, retaining fluid, and the gynecomastia, impotence, testicular atrophy, amenorrhea. Those are all symptoms of Cushing's. So that totally makes sense. Make that connection there. Other late clinical manifestations are related to splenomegaly. So when the liver fails, oftentimes the spleen goes with it. It's almost like they're in a partnership. So the spleen's having issues because the liver is going to, if the liver is not functioning correctly, then the portal vein is not going to be getting drained correctly. And the portal vein, remember, is what's taking blood from the GI organs, including the spleen, and getting filtered through the liver before it goes to the heart. Well, if that portal vein's backing up, then blood is backing up into the GI system. It's backing up into the stomach, the intestines, the large intestines, the esophagus, the spleen, the pancreas. All of those organs are getting affected. And we call that portal hypertension. We're actually going to talk about that in a few slides. But when the spleen isn't working, we're going to see decreased amounts of our cells. We're going to see thrombocytopenia, which is decreased platelets, leukopenia, which is decreased white blood cells, and anemia, which is inadequate red blood cells. And all of those are bad, especially, so your thrombocytopenia, your decreased platelets. Platelets play a role in clotting. And then because we already have liver failure, meaning that we're not producing adequate clotting factors, the patient's going to be at risk for hemorrhage and bleeding. So you could see things like epistasis or prolonged nose bleeding, petechiae, which is the small little pinpoint bruises that patients can develop, gingival bleeding, gum bleeding. They can brush their teeth and they're going to bleed like crazy. Heavy menstrual bleeding if the patients are young enough to still have menstrual cycles, and easy bruising. So if you start seeing that, they're definitely getting to a point of late cirrhosis here. The leukopenia, the decreased white blood cells, put them at risk for infection. So that's really bad. We need to really be on top of our hand hygiene and decrease their risk for infection in the hospital, but also educate them on how to lower their risk outside of the hospital. And then anemia, not only are they at high risk for bleeding, but they already have a low blood supply, so that can lead into some dangerous realms. They may need some blood transfusions. And then we're going to see deficiencies in proteins because, not proteins. We will see deficiencies in proteins and deficiency in albumin. We'll also see deficiencies in vitamins. That's what I was getting at. So we'll have a thiamine, folic acid, and vitamin B12 deficiency. These also all play a role in proper RBC production. So not only is the spleen not able to help produce red blood cells appropriately, vitamin B12 plays a role in properly forming hemoglobin and red blood cells. So if that's low, then we're further anemic, and they're going to need things like banana bags. So we call, if you've ever seen these in the hospital, they are yellow, they look yellow, IV bags. We give them to patients who are alcoholics, chronic alcoholics, to help restore some of their thiamine, folic acid, and B12. We would also give this to a patient that has cirrhosis, replace it IV. There are ways to replace this PO. You can take a PO, thiamine, folic acid, or B12. Peripheral neuropathy occurs with these vitamin deficiencies. So they may have things like pins and needles in their extremities, just like with diabetic patients that develop peripheral neuropathy. They may not be able to sense things as well. So they could have wounds to their feet, not know it. That can lead to delayed healing, et cetera, et cetera. You can see how all of this can just like snowball into more and more complications. So now we're going to talk about portal hypertension. And this is one of those gray screens. This occurs in combination with the liver failing. So portal hypertension is a fibrous connective tissue in the liver disrupts blood flow. So that nodular change in tissue formation and cellular formation will disrupt normal blood flow. And we talked about this. Obstructive flow will increase pressure in veins, and those veins are in the spleen, esophagus, stomach, abdomen, rectum, and varicose veins. So we're literally going to see this be displayed in multiple different organs. And we talked about these major GI organs. In the abdomen, we'll see, let me show you here. This here called caput medusae. So I think of it like Medusa from, what is it? The Little Mermaid? That's a lie. What's Medusa from? She's like a Greek god or something. Oh my God, I don't even know. But she got the crazy snake hair. That is so not the Little Mermaid. I don't even know what I'm talking about right now, but they have the crazy snake hair, and that's kind of like what this looks like on the abdomen. It's this crazy, you can literally palpate these veins. They're so engorged, and you can see it on their abdomen. It's so crazy. And then we can see it in the rectum, and you can get hemorrhoids from this, and then varicose veins, which we're going to talk about in a couple slides. Actually, we're going to talk about right here. So varicose veins can occur in the esophagus, varices, and gastric varices. And then they also can cause, do we see varicose veins down here? Whatever. You can also get varicose veins in like your lower extremities because you're having backflow. And anyways, gastric and esophageal varices are dilated, tortuous veins. So just like you would see varicose veins in the legs, picture that. If you've seen anybody that have them, they're really dilated, engorged veins in the legs. Even right here on the abdomen, you can see they're dilated and engorged. So the veins within our organs in the esophagus and in the stomach become engorged and enlarged. And large engorged veins tend to be more fragile and bleed easily. The problem with that is because if we start having bleeding vessels in the esophagus or the stomach, then they are life-threatening. It is the most life-threatening complication of cirrhosis because it can cause like severe bleeding, and the patient can develop hemorrhagic shock and bleed to death essentially from this. Signs and symptoms of this are projectile bloody vomit. The treatment is going to be prophylactic treatment and prevent recurrent varices. So if we can identify that this patient has varices with their cirrhosis, then we want to give them things like beta blockers like propranolol, PPIs, proton pump inhibitors like pantoprazole or Protonix, and then histamine receptor blockers like ranitidine or Zantac. If the patient is experiencing active bleeding from their varices within the esophagus or the stomach, then we want to give them a medication called sandostatin or octreotide or IV vasopressin. Both of those provide vasoconstriction and can minimize the amount of bleeding that would occur. And then, of course, we want to do blood replacement, PRBCs, FFP to restore clotting factors because we are in a cirrhosis. You get this with cirrhosis. So we also have liver failure underlying this and decrease in clotting factors. So we want to restore clotting factors. FFP is one way to do that. Cryoprecipitate is a way to do that. That's a specific fibrinogen derivative. And of course, we know we're not producing fibrinogen in liver disease. And then vitamin K for clotting abnormalities, as we've previously discussed. Other ways we can treat this are to go in surgically. So we can do endoscopic injection, go in endoscopically, insert the tube and the camera through their mouth, and then do something called sclerotherapy, where we inject a sclerosing drug into the varice, which will cause the bleeding to stop. We can also do an endoscopic, same way, go through the mouth, variceal ligation, where we kind of put a band around that varice, around that vein, and it'll cut off blood supply to that varice and essentially kind of cause it to die and slough away. That sloughing will develop into a superficial ulceration within 3 to 7 days and then can heal from there. We can also do something called a balloon tamponade, where they're just like with the balloon tamponade for like a cardiac cath. You go in there, you can balloon it up. Same thing with achalasia. We do the balloon tamponade. You get into that narrowed space. This would be where the bleeding would be. You open up that balloon, and that direct pressure from the balloon is going to cause the bleeding to stop. Just like if you had a cut on your arm and you put direct pressure on it to stop the bleeding, same concept. Tubes that these patients can have post-procedure, they can get a Sing-State Blakemore tube, a Minnesota tube, or a Linton-Nicholas tube. Depends on your surgeon and the facility you work at as to which tube you're going to get, because that balloon tamponade will stay in there for a minute. Well, we'll talk about it in the next slide here. So this is what it looks like. These are what the esophageal varices look like. We can go in and ligate and do the sclerotherapy, put a band around the vessel here and cause it to, will stop the bleeding, and then it'll turn into that superficial ulceration and heal. And then we have the ligation where, well, that's the band, sorry, the band there. You can also inject a sclerosing drug directly into that area. The balloon tamponade, here's where we're going to talk about a little more detail. So this picture shows us here where the balloon is going in through the nasal cavity and getting passed straight through the esophagus, just like you would do an NG tube. And wherever that varice is where the balloon is going to blow up and cause that direct pressure. If it's down towards the esophagus and the balloon's, or down towards the stomach, then the balloon will be in the stomach and put that pressure on the stomach. Complications that can occur with this are esophageal necrosis. So if the balloon is in place longer than 48 hours, then that could be a potential complication. So the balloon should never be in for longer than 2 days. Because not only is that pressure stopping the bleed, but if it was in there for too long, it's going to cut off circulation completely and cause necrosis of the esophagus or the stomach. Aspiration pneumonia can occur. Obviously, we want to suction secretions frequently. They're not going to be able to swallow as adequately as before they had the tube in. So we need to suction. The area where the tube is in place can cause erosion from just like sitting up against the nostril. So making sure we like kind of move the tube around and readjust it for the patient. And then they're at risk for airway obstruction. I've never seen this procedure done where the patient wasn't intubated. I think theoretically you could do it without the patient being intubated, but that's just not something I've seen done. They intubate you for the surgery, and then instead of extubating you, they just keep you intubated while the balloon's in place. They take you back to surgery or endoscopy, wherever they do this, deflate the balloon. Some places do it in the endoscopy suite. Some places do it in the OR, deflate the balloon, pull it out, and then you can extubate the patient. Another thing we can do is something called a TIPS procedure. And you may have heard about this in like certain medical shows talk about it. It stands for transjugular intrahepatic portosystemic shunt. So obviously this is why we call it TIPS for short. It's a mouthful. It is a surgical or non-surgical procedure depending on how severe or unstable the patient is. There's a stent that's placed in the hepatic vein. And so basically we're going to put a stent in there just like we would for the heart. And it's going to control bleeding by reducing portal vein pressure. It basically adds an additional pathway for blood to go to relieve some of the built up pressure in the portal vein. And which one of those procedures the patient receives depends on where their varices are, what surgeons are available, what those surgeons prefer to do. So they could get any of those procedures. Another thing we're going to see with cirrhosis is peripheral edema and ascites. Ascites, it's an accumulation of fluid in the abdominal cavity, so you can see that here. I'm sure in some of the lung care long-term care facilities that y'all have worked with, you've seen this before. It is fairly common. There are 3 mechanisms behind why a patient would develop ascites with liver failure. First of all, the lack of albumin. So the liver isn't working, it's not producing albumin. We've talked about albumin keeps volume in the vascular space. So if we do not have enough albumin, then there's nothing keeping, my cat is going nuts, I'm so sorry. Then there's nothing keeping the volume in the vascular space. So we're going to third space. Then there's an increase in hydrostatic pressure. That's what we've been talking about with portal hypertension and the engorgement. The congestion of blood is an increase in hydrostatic pressure. And then hyperaldosteronism, because aldosterone is not getting metabolized, it's staying in the body longer, and we are retaining sodium and water. So all 3 of those things will combine lead to ascites and peripheral edema in the legs. So what are we going to do for patients who have ascites? Well, we want to assess their abdominal girth and weight gain to try to monitor how much fluid they're retaining at a time. They should be on a sodium restriction. It is based on the degree of ascites that they've experienced. The doctor will let us know if they need that. Initially 2 grams a day. If they are severe, if they're having like a lot of complications from the fluid retention, then they may need to go on a 200 to 500 milligram per day restriction of sodium. Diuretics that we can give them, potassium-sparing diuretics are spironolactone or aldactone, so we can give them. They will diurese and not pee out their potassium. Loop diuretics do pee out potassium, so when we give furosemide Lasix, we talked about this in heart failure in the cardiac section. When you're peeing out Lasix, you're also peeing out potassium, so we would want to be aware of that. And then we also want to give albumin back to them, IV albumin, to maintain their intravascular volume and support their blood pressure and volume status. Further treatment that we can do, it's called a paracentesis. So this is pretty cool. We actually have the MD, the doctor will insert a needle into the peritoneal space, and then that will kind of drain fluid, the excess fluid, out into a bag. It's just like this procedure shows. We don't use a bag at U of L, we use a vacuum bottle. So they spike the bottle with the needle in the peritoneal catheter that they stick in, and they'll drain it out. And they will remove a large amount of fluid, but also protein. So a lot of times when patients are getting a paracentesis, they're simultaneously getting albumin infusions. This is a temporary treatment. This does nothing to address the liver failure. It's just addressing the symptom of fluid retention. And the nursing care during this procedure, it's done at the bedside all the time. We can also take them down to IR, interventional radiology, to do this. Obtain weight and vital signs. They need to void before the procedure to minimize their bladder, decrease the risk of puncturing it on accident. And then after the procedure, we're going to monitor for bleeding. Of course, they're in liver dysfunction, so they're not producing enough clotting factors, so they're at high risk of bleeding regardless. Their vital signs, and then again, replace the albumin. And then another thing we can do for patients who chronically have issues with ascites is insert a I can't ever say this. A peritoneovenous shunt. Whatever. We put a shunt in and it will drain the fluid because your peritoneal cavity is sterile. The cavity is going to drain that fluid back up into the heart. There is a one-way valve that inserts into the abdominal cavity, and then it sends it back up into the either the subclavian or the jugular vein to then be reperfused through the body. Again, this is okay to do because the peritoneal space is sterile. All right, so hepatic encephalopathy, and this is where I was talking about ammonia comes into play. So when there is an accumulation of neurotoxins in the blood, particularly ammonia, then we have a encephalopathy of the brain. So encephalopathy, encephalo is brain, pathy is a disease of, so we have a disease of the brain. Signs and symptoms of encephalopathy are like altered mental status. I mean, that's the main thing. They're just confused, agitated, just like out of their head. Because in the GI tract, bacteria break down proteins into ammonia. That ammonia gets brought to the liver by the portal vein to be converted into urea. Then that urea would be able to be peed out, and that's what gives your urine that ammonia smell. If the liver isn't functioning correctly and it's unable to convert ammonia to urea, then it's going to build up. It's neurotoxic to the body. It's going to cross the blood-brain barrier and cause an encephalopathy to occur. The hallmark sign of hepatic encephalopathy is the liver flap, asterixis. And you'll actually see their hand do this liver flap. And then the treatment goal is simply to get rid of that ammonia. We got to reduce those ammonia levels. As soon as we do, they're going to start regaining orientation and become less and less confused. So our treatment is going to be lactulose. If you've ever given lactulose, it's a horrible drug to give. It's good for the patient, and it's amazing to see them turn around so quickly. Excuse me, but it does cause them to have a laxative effect, and they are pooping so much, and they're confused, so you're cleaning them up in bed. Even if they're normally a functional individual, they're very sick right now. Lactulose is going to trap that ammonia within the GI system and cause it to be pooped out. It won't even go to the liver. We'll just get rid of it. We can give it orally. It's this nasty liquid that we have to get the patients to drink, or we can give it by an enema. I hate both, but it is amazing to see the patient go from completely altered and confused, and then even in as little as a 12-hour shift, they can turn around. It's pretty cool. Antibiotics that we can give are going to decrease bacteria in the colon. Those can be neomycin, flagyl, vancomycin. And then the symptoms, if severe, we're going to decrease protein intake. However, in most patients that I've seen with hepatic encephalopathy, we've not had to do that. We actually want to encourage protein intake to help repair tissues. Hepatorenal syndrome. This is something we're just going to briefly touch on because we're going to go into more detail of it in the renal and urinary section. Get off of that. I swear to God. Come here. Come here. Quit. Just sit here. Quit acting crazy. Sorry, guys. So the portal hypertension is going to cause blood to back up to the kidneys. It's going to cause blood to back up into the GI system and not provide enough blood to the kidneys. If the kidneys are not getting perfused, then it's going to lead to renal failure. We're going to talk about renal failure in detail in the renal section, so do not get into detail on this slide. You don't need to know a lot. What we are going to see is decreased urine output, elevated BUN and creatinine levels, and that's an indicator of kidney failure, and then increased urine osmolarity, meaning that the urine is going to be more dilute because the kidneys can't filter properly. And then diagnostic studies that we're going to do for patients in cirrhosis, we're going to see increased liver enzymes because it's not functioning correctly. Bilirubin is going to be increased, and the PT is going to be increased because bleeding time is prolonged. Same things as we saw in the earlier slides with hepatitis. We're going to see a decrease in the total protein and albumin. And then we can do a CT and ultrasound to see the extent of cirrhosis and what other additional complications they may have. And a liver biopsy will confirm the diagnosis of cirrhosis. And then again, just make sure you know the nursing care management of a patient who's had a liver biopsy done. Other nursing diagnoses to keep in mind: ineffective tissue perfusion. We want to prevent hemorrhage from esophageal varices. So remember all of those different ways we can do it. Sclerose and ligate, balloon tamponade, all those good things. The drugs are propranolol, PPIs, your pantoprazole, and your Zantac, and then what else do we do? We do octreotide or IV vasopressin. So that's how you guys think about these slides. Start tying them together. No ingestion of alcohol, aspirin, NSAIDs, or irritating foods. Also Tylenol. So alcohol and Tylenol will irritate the liver and not get processed correctly. Aspirin, NSAIDs, and irritating foods will worsen bleeding. So they do not need to take any of those medications if they have cirrhosis and portal hypertension. They need to chew their food well, especially if they have esophageal varices, because they don't want to irritate them as they're swallowing. And then treat upper respiratory infections promptly. We don't want those to get transmitted into the GI system and cause problems. Why are we going to see impaired gas exchange with portal hypertension? Really think about that. What's going on here? So if we have a patient with liver failure that has led to portal hypertension and ascites. Ascites takes up so much space within the abdomen and the peritoneal cavity, it's going to put pressure and decrease the space in the thoracic cavity. Our lungs aren't going to be able to expand properly, so we'll have impaired gas exchange from that. And then acute confusion, why is that? That would be if a patient went into hepatic encephalopathy. Safety is a huge thing. They are definitely going to be a falls risk. They're completely out of it. They don't know what's going on. They're going to keep trying to get out of bed. So all of your nursing management techniques for patients who are a falls risk, what do we do for them? Well, we put the fall socks on them, the non-skid socks. We keep their rails up. We keep their call light in place. We frequently round on them. We try to reorient them to where they're at over and over again. We can do bed alarms. We can put signs on their door, this falling star, to let people know that there's a falls risk. We need to escort them to the bathroom, address things like that when we go and round on them, address pain, potty. What are the P's? I don't know. Pain, potty, PO, so food or drink. Address those things when you're in the room so you give them less reason to need to get up and potentially fall. For jaundice, we're going to observe sclera in the, we're going to observe for yellow discoloration in the sclera, skin, and hard palate. It can be a little bit more difficult to identify jaundice in African American folks, so we would want to look specifically at their sclera and hard palate. Pruritus, how do we manage that? We can give antihistamines, but definitely want to avoid over-sedation. And then other measures for pruritus can be baking soda or alpha carry baths, use lotions containing calamine, turn the patient every 2 hours and support their abdomen with pillows, and then keep their nails short so they don't scratch themselves. And then if they do have to itch, they need to do it with their knuckles and just kind of rub because they don't want to cut themselves. And now we're going to get into pancreatic and biliary disorders. So take a breath. You have made it through the liver section. I know that was a lot of information. Now we're going to get into pancreatic and biliary disorders. And I think just for your all's sake, to break it up, I'm going to stop here and then I'll restart right away. So as you're listening, you can kind of break up and pace yourself here. So I will be back with another Zoom in just a minute.